Well, good afternoon, ladies and gentlemen, and a warm welcome from a cool Cape Town. This is the Pelvic Floor Foundation's Series 4, Episode 8 of the Zoomers. Steve, we've been here for many, many years, and this is Episode 8.
I don't know where you got those maths from, but sounds good.
Sounds good. And it's a great pleasure to introduce our speaker, but first we're going to introduce our sponsors. Remember that FIGO is coming up soon. There's 74 days to FIGO, Steve. And we've had a lot of interaction with FIGO. We had the president of FIGO here. We had the next president of FIGO here. And they're going to be speaking soon. We've signed them up. And Chris has got hold of their emails. And they're going to be speaking on things like vaginal delivery of breech and maternal mortality. It's going to be a wonderful, wonderful session. We've also got a session on PCO coming up. But before we introduce contraception through the ages of women, including LARCS, and that's Judy Kluge, who's presented many a time. I'd like to ask Zelda of Bayer, firstly, by thanking you very much indeed for sponsoring this session. And then, Zelda, are you going to launch and project your video?
No, we can just play. Thank you so much. Thank you for always having us. It's a privilege. Thank you, Chris.
Thanks, Chris. Hit it.
Every single month, blood. So much blood. The lost moments, the sacrifices I've made. Is this heavy period normal?
I've been told it's common in menopause, but my whole body's on fire. Dripping sweat. The sleepless nights, ups and downs. Is it normal I suffer in silence?
The desire's gone, vanished. The growing distance, feeling sad, guilty. Is this quiet battle normal?
Every time we get too close, the anxiety hits. What if I get pregnant? Is this fear normal?
With every period, the cramps, the agony. I'm the one who misses out, can't be there again. Is this unbearable pain normal?
You know what hurts in women's health? Being told everything is normal. Because if something is holding us back, it's anything but normal. It's time to question what we've been told and confront what we've accepted. It's time to reclaim the moments we've missed. Women by Bayer is here to reveal what's not normal in women's health. Raise your voice and share your story at women.bayer.com. Together, we can create a life without compromise and embrace every single moment.
Thank you very much indeed. Is it on, Steve?
Yeah,
great.
Good.
Thank you very much indeed, Zelda. It's been wonderful to have Bayer as a sponsor for the Pelvic Floor Foundation in the past, and I hope to continue in the future. It's wonderful, and thank you very much on behalf of the Pelvic Floor Foundation. And now, ladies and gentlemen, we've spoken about FIGO. That's 74 days from now in Cape Town, right next door to where we are now, and it promises to be a stunning presentation. Steve's doing presentations, so that certainly ups the ante. And some of his friends are going to be there, like Dudley Robinson and JP Rubis. So it's a stellar performance. But first, talking about stellar performance, we have Judy Kluge. And she's going to be talking about contraception through the ages of women, including LARCS. Wonderful to have you, Judy. And thanks again for being able to do the presentation.
And before you start, Judy, maybe you can just give us a quick update. Are you still doing your subspecialty training at Tygerberg, or are you done with that?
No, I've got 5 months left of my Urogyne subspecialty training, and don't ask me what I'm doing next year.
What are you doing next year? Oh, don't.
Well, at the moment, my focus is just to put butt to chair and pass the exams, and I hope to do an observership in Australia next year. And then once I've passed and done that, I'm going to see where the world takes me.
I'm sure there's going to be ample offers and opportunity for you.
The world's your oyster.
Yeah, thank you. Okay, so this is an old topic of mine, but I have added some breaking news to the presentation. So we're going to talk about contraception through the phases of a woman's life. But I'm going to start with a bit of what's topical at the moment, a bit of a breaking news, and then I normally like to introduce hormones used in contraception, because it's something that people do struggle to follow, and then we'll go through using the different contraceptive methods at different phases in a woman's life. But I have to first share what was, because I asked on my book club, does anyone have, which is mainly gynaes, does anyone have something to ask to help inspire me? And this is what I got back from one of the colleagues: an antenatal maternity case record. And you'll see this is a 40-year-old, gravid at 10, para 9. I must compliment her, because except for the 2 pregnancies in 2006 and 2007, she's generally stuck with a birth interval of 2 years, which is what we at least recommend. So she's had a pregnancy 2009, 2011, 2013, 2017, 2019, 2021, 2023, and now another one in 2025, and she's 40 years old. But what made my eyeball twitch and lose all hope to live is, if you look at the future contraception, what do you see there marked? Injection. And if you have worked in the state sector, for me, injection being ticked means the contraceptive counseling was, what are you going to use? Injection? Okay, that's great, tick. I hope many of you who see this maternity case record will hopefully offer this patient something else other than injection. But if any of you think, well, what's wrong with this maternity case record, as long as it's her choice, let's go to the next breaking news, which is, yes, she's chosen an injection, but back in January 2025, SAHPRA came out with a warning. And SAHPRA warns of increased brain tumor risk with specific contraceptive use. And what they're actually talking about is medroxyprogesterone acetate in its various formats, either the Depo or in Provera. So this, I don't know if any of you have heard about, it was a bit in the media. What was interesting for me, which I didn't know, is, of course, we've used high-dose Provera and medroxyprogesterone acetate for endometrial hyperplasia and even in endometrial cancer, but I didn't know that it is sometimes used in palliative treatment for women with renal cancer and breast cancer. So that was quite interesting. But so when I heard this, I was like, oh, bugger, because when I worked at PAL, we were actually restricted how many implants and IUDs we were allowed to use because of the cost, because in PAL, the slogan was always stop and save. And then the pharmacist would say, oh, but you can just use the Depo-Provera because it's much cheaper for the hospital than to put in an implant. And I've always said you need to spend money to save money, but unfortunately the powers that be in your institution might say, well, it's somebody else's problem. But what I'm trying to say is, if we have that attitude, it's all going to become our problem, because it's not about just having these children born. it's also like all the resources to care for children. Our other joke in PAL always used to be is that we have a grade R class born every year in our labor ward, because there's at least 30 deliveries in the labor ward every day. And but yet do we have schools to actually care for all these children? So but in any case, going back to this link between medroxyprogesterone and meningioma, where does it actually come from? Well, it comes from two epidemiological studies conducted in France and United States, which observed an increased risk of cerebral meningioma with prolonged use of medroxyprogesterone acetate. Basically, over 20 years, there was globally 32 cases had been reported, so extremely small numbers. And so the absolute risk of developing a meningioma is small, given the widespread usage of medroxyprogesterone acetate containing products. Currently, there have no cases been reported in South Africa.
Judy,
So
Judy, how do
Yes.
we know there's an association? Isn't this pure chance? Because there must be quite a number of meningiomas in the world and quite a huge number of Depo-Provera users. How do we know there's
Yes.
a relationship?
Well, I'm going to show you another slide because it's not just medroxyprogesterone acetate. There's even a link with normogestrel acetate as well, because I'll see there's even a Zoli warning. Well, there's a position statement about it, but I think it's like, yes, this is the problem with epidemiological studies is that sometimes there's an association, but it doesn't always imply a causal association.
Correct.
I mean, if you look at that, the other big drama that was a few years ago, which was Mirena and breast cancer, yes, that was also based on a large Finnish epidemiological study. But once again, you always have to question yourself, well, can you compare apples to apples? Are the Mirena users the same people as the people who don't use Mirena? So maybe there's an innate, so there's an association, but is it actually a causal association? Can't always be answered in these epidemiological studies. I hope that makes sense.
Thank you.
But if you work in the state sector, the Western Cape issues these circulars, and in May of this year, there was a circular that came out, and it is on the National Standard Treatment Guidelines and Essential Medicine List that was also updated. And there's now a cautionary notice that have been added in the Essential Medicine List on long-acting medroxyprogesterone acetate. And what they actually advise is that alternative contraceptive options should be considered if the continued use of medroxyprogesterone acetate is extended beyond 2 years. And all effective methods should be considered and taken into account. There's a small increased risk of meningioma, rare and mostly benign, has been reported following long-term administration. And if you have a meningioma diagnosed, they advise that you discontinue your long-acting medroxyprogesterone acetate, and caution is advised if there's a history. So the thing that always concerns me with these things is because I often feel it's like a little storm in a teacup, and then everybody's like, okay, there's now these risks, everyone's going to stop using Petagen, and we already have so many limited choices and all these fears that have been especially with lay media, all these fears about contraceptives. And so I always like to say, well, life is full of risk. Sometimes it's the driver driving the car, in other words, the doctor. Sometimes the car is a skodonk, the patient, and sometimes it's the taxi that comes from the side and smashes you unexpectedly. But not every time you get into a car, you're going to die. And unfortunately, you need to decide. But I always but often when there's something like this comes out, then people go, it causes brain cancer, you must stop. And this is the problem with how media, and how do you actually give risk or portray risk to patients? So we're now advised to tell our patients about this risk, but I always think you must be cautious, because sending your patient away with no contraceptive, for me, is more dangerous than giving a contraceptive. So unfortunately, pregnancy, I think, needs to come with a warning, but unfortunately, a lot of people don't see it the way I see it. But going back to this high dose medroxyprogesterone or prolonged usage, what's also interesting is that there has been an association found with normogestrel acetate and also meningiomas. So this actually statement comes from the Faculty of Sexual and Reproductive Health. The reason why I found this was I was actually looking, well, SAHPRA has now issued a warning, so what is everybody else doing? So I couldn't find anything from the Society of Family Planning, which is the American organization who's sort of the leaders in contraceptive guidance. The Faculty of Sexual and Reproductive Health is now part of the RCOG, and they didn't have any statements. Apparently, the reason why SAHPRA came out with a statement is because there have been, I think, some litigation or some regulatory concerns in Europe. The SAHPRA was notified, and hence they had to include it. But as yet, so maybe we're just ahead of everyone else. I think we're the only one of the few regulatory bodies who actually have mentioned something with medroxyprogesterone acetate. So, but I did find this statement about NOMAC, which is the progestogen that's in Zoli, because they've also found a increase in risk in people who use high dose normogestrel acetate, but that is not the same as the dosage in Zoli. So the dosage of NOMAC in Zoli is much lower than the dose that has been used where it's been linked with meningioma. But I thought you might find that interesting. Okay, but so that's my news flash. So what now is concerning me is that some intern has read the SAHPRA and this Gravida 10 para 9, who only seems to want to use Petogen or Depo-Provera, is going to be told, no, you can't use that. You're going to get a brain tumor. We'll rather send you out with nothing. So, and so that gives me sleepless nights. And what we need to think about is that there are many options, and there are non-hormonal options, other hormonal options, and like most things in life, we need to balance the risk-benefit. So when you consider a contraceptive method, you want to use something that works well. And in my clinical practice, I've generally found if you give women accurate information, and one of the first things I do to start the conversation is actually, how well does your birth control work? There are very few women who will knowingly choose a lesser effective method because of health concerns. So most women, in my experience, do want contraceptive that is reliable, and what we call the top tier contraceptive method. So if you look at the top, there's the top tier are all what we would consider your long-acting reversible methods, except for, of course, the sterilization. But your implants, your hormonal intrauterine devices, and your copper-containing. And then you can help explain the risk or the efficacy by saying, look, there's 100 women here, less than one of these will fall pregnant using this method. So the perfect use and the typical use failure rate of these long-acting methods are very much the same. The other thing is that when you look at contraceptive choice, if you give women accurate information, generally the women who choose a LARC fare better. So this is an old study, but I think it's very important to to know about it because it was a large study, and it's called the Contraceptive Choice Project, which was a prospective cohort study of over 9,000 women. So a very large study that is unlikely to be repeated again sometime soon, of women in their reproductive age ranging from 14 to 45. If they got a structured counseling method. So in the study, it wasn't what the provider just felt like talking about that day. It was a structured interview with a structured counseling. So basically all the participants got a structured counseling session. And if you give women adequate counseling, the majority of those women in this study chose a LARC method. So 75% of these 9,000 women actually chose one of the 3 long-acting methods. The majority of the women chose a levonorgestrel intrauterine system, 12% a copper IUD, and 17% subdermal implant. And when they followed those women up, they found that the women who chose a long-acting method was more likely to continue that method than non-LARC method. So if you look at efficacy or how well contraception works, if you have, you also need to consider what is the likelihood that your patient or your woman is going to still be using that method after a year. So this is what we term the continuation rates. So generally 87% of women who chose a LARC method were still using it, versus 57% of the non-LARC users, and the continuation rates were still pretty good at 2 years. And why is that important? Well, not only, even if the patient, like the other patient, you want to have 10 kids, you want to try and delay. We know health of both the mother and children is improved when you delay the next pregnancy. So LARCs were 20 times more effective than non-LARC methods, and this resulted in substantial reductions in teen pregnancy, birth, and abortion. So what does this choice study tell you is that we need to have a structured approach at offering everything that women are medically eligible for. So the next question I often get asked is, what is the ideal contraceptive method? Well, you generally want to use something that is safe, because that is a woman's other health concern is this method safe for me? And the World Health Organization has the medical eligibility criteria, which basically I call it the idiot's guide to giving contraception. Basically, you just need to know category 1 means there's no risk to the patient. Category 2 means there might be some risk, but generally the benefits outweigh the risk. And category 3 means generally don't use unless there's nothing else available. And category 4 is do not use the method. Sadly, every year when there's a new batch of interns that come up in the labor ward who are encouraged to start counseling women on contraceptive before they go into labor, then a lot of them still give me these googly eyes about what is a WHOMEC, which means that the respective training institutions are not emphasizing how to provide contraceptive safely. And the WHO MEC is considered one of the 4 pillars of providing contraception. So you generally want to give something that is safe. So you use 1 or 2. Granted, I have provided methods that are category 3, which means generally don't use unless there's nothing else available, because pregnancy carries more risk than the actual method. Then, as I've mentioned before, most women generally want to use something that's going to work, where the efficacy is good, the top tier. And those are your LARC, your fit and forget method. But some women would like to use a contraceptive method for non-contraceptive benefits. So the way I try and talk to women and say, well, hormones or synthetic hormones that we use in contraception, we can use for many things, but actually the side effect is that you don't fall pregnant. So, contraception is not just about preventing a pregnancy. It's by improving health. And I think, I don't know about you, but I was a little bit tearful when I looked at that Bayer video, because that's exactly how women, I think it shows that women are getting a voice, are basically saying, what have we told that is normal, we shouldn't take as normal. And there are so many options to actually make us have a better life, that we shouldn't be hindered by our reproductive organs to prevent us from fulfilling our potential. So, and of course, your contraceptive needs will change as with women over time. And I think that was the nice thing about that Bayer video, is that it actually had the teenager, the young woman, the older perimenopausal woman. And so your needs might change over time. And why might your contraceptive method change? Well, your need for efficacy might change, because with aging, there's a natural decline in our biological fertility. And then maybe the method that's not necessarily the higher effectiveness on that chart might be, but for your age group, it might be a very good method. Then you also need to consider the emergence of age-related comorbidities. And this Faculty of Sexual and Reproductive Health has a whole guideline on contraception for the woman older than 40. And why? Because that's the woman who's going to experience breast cancer, who's going to have probably heavy menstrual bleeding, or have heart disease, or be obese, or who smoked 30 cigarettes a day for the last 20 years. So what might be ideal for you at 20 might not be ideal for you at 45. And then other symptoms of coexisting conditions like perimenopause. And then also there's the development of new contraceptive technology. What was available 20 years ago might not be, what wasn't available 20 years ago might be a better option for you now. So what are the non-contraceptive benefits that we can provide with contraception? So this is specifically focusing on combined hormonal contraception. We're going to talk about progestogen-only method a little bit later, but we know that combined hormonal contraception, any method, actually can decrease heavy menstrual bleeding. And in actual fact, the method that contains estradiol, valerate, and dynagest, the trade name otherwise known as Clara, is FDA approved for heavy menstrual bleeding. And by the way, just to give me a time, somebody must just give me a time check so that I know if I must hurry or not.
No, you're doing good.
Okay. And then things that decrease iron deficiency, dysmenorrhea. We know contraception decreases your endometrial, ovarian, colorectal cancer. And then your other pregnancy-related conditions like ectopic pregnancy, and even premenstrual dysphoric disorder. We know that your drospirenone containing pill, trade names being Yaz and Yasmin, actually do help with premenstrual dysphoric disorder, and then of course pelvic inflammatory disease. Other use for management in gynecological conditions: decrease in functional cyst formation. So it's not it won't take away a cyst, but because the vast majority of cysts are functional, it will just suppress follicle formation and hence prevent further functional cysts, so if that's a problem. Treatment of endometriosis, treatment for other hyperandrogenism conditions where there's hyperandrogenism like acne, hirsutism, and PCOS, and then cycle control or unscheduled bleeding. So we know combined hormonal contraceptives has a better bleeding or scheduled bleeding profile than your progestogen-only methods, and that's the downside of any of the progestogen-only method, is the unpredictable nature of the bleeding pattern. We know the higher the dose of estrogen, the better the cycle control. And we also know that if we give a combined vaginal ring, which actually gives you 15 micrograms of EE, you even get better scheduled bleeding than the 30 microgram EECOC version, and also the patch. So also the route of administration of the ethinyl estradiol can help with the bleeding.
Judy,
Yeah.
sorry, you were just about to ask a question, Steve.
Yeah, no, I mean, we were just wondering about the ring. So it's something that maybe seems to be used that extensively, but is that what you?
Yeah, I was asked the same question. Why in Europe is the ring so popular? And I don't have any patients at all on the ring, but Steve has one. So why is there such a lack of popularity, shall I say, for a good method in this country, whereas other countries seem to enjoy higher popularity for this?
Yeah. So do you want to hear my cynical version, and then I'll tell you my academic version? My cynical version is both doctors and patients are scared of the vagina. That's my cynical version. The academic version is, I'm not sure particularly why. I think this goes to probably the healthcare provider, because I don't know the private gynecologists on this talk, how often do you even mention NuvaRing as an option? It might be because they themselves are ignorant about it, and that's what I was trying to show, that a lot of people say, well, why is there even a place for NuvaRing in the market with so many choices? And I'm trying to say, yes, there is, because one of the things that bothers women the most with methods is the unscheduled bleeding. And we know the lower dose you go for your ethinyl estradiol, the more breakthrough bleeding that you can get, especially if you miss a pill. And we know that up to a quarter of women will miss a pill in one packet every month. So breakthrough bleeding is not uncommon. And the lower you go, and you can correct me if I'm wrong, we used to have Menes, which is the ultra low dose pill, which had 15 micrograms of ethinyl estradiol. That's no longer, I think, even available. Whereas the NuvaRing, you can give that low dose ethinyl estradiol without compromising on breakthrough bleeding. So you get better scheduled bleeding with 15 on a NuvaRing than with 30 in a tablet.
Okay,
so,
thank you.
For me, it has its place. And there are, hopefully you'll see later, there are going to be some women, you might also say, well, why do we even use pills with ethinyl estradiol anymore? And I want to say, well, sometimes you want ethinyl estradiol compared to your more synthetically natural structured estrogen, if that makes sense.
Yeah. Yeah. So can I ask another question? They're coming in thick and fast.
Yes.
How do you have any experience with the use of endometriosis in the pill? Because we had a talk by Toby de Villiers about 2-3 months ago that said that it seems to be slightly controversial whether you do or don't use endometriosis, the pill for endometriosis. What are your feelings?
Yeah, well, I think also I listened to Dani Botha also mentioned this as well in the talk.
Yeah.
And so my answer is going to be very similar to his. We know that you're going to have any pill, combined pill, can generally you have less bleeding than a natural cycle. But also if you tricycle, you can do extended regimens or tricycling. And this is also the other thing that I don't know if it's particular for South African women, is this notion that you have to bleed. The Faculty of Sexual and Reproductive Health has for many years advocated what we call extended use regimens, where you don't give yourself a fake period. And essentially you then suppress you just don't cause your endometriosis to bleed, because you suppress it by giving the same dose of hormone every single day. Yeah. So it does definitely help with endometriosis, but you get more additional benefits with your regimens, your extended use regimens. And then, of course, you're going to get more and more benefits if you're using an estrogen that's a weak fertilizer, as I always say, but a strong lawnmower. Those of you who know me, I always talk about that analogy of the fertilizer being the estrogens and the lawnmowers being the progestogens. And sometimes the problem with bleeding is you've got a very strong fertilizer but a weak lawnmower, or you've got a very strong lawnmower and a weak fertilizer, if that makes sense.
Yeah, no, you're right. It's the same thing about why don't more women use the ring, and why don't more women eschew or avoid periods? Because there's nothing that says in life you've got to have periods. And
Yeah.
how long would you go without having a, not you, but your patients go without having periods? In other words, you do tricycling, everybody agrees, but can you go 6 months without breakthrough bleeds? 9 months, maybe a year? Does it matter?
No, it doesn't matter. And actually, the extended regimen of use in the Faculty of Sexual and Reproductive Health says you basically take active pills, and you never have a withdrawal. The only time you have a withdrawal or take your placebo is if you then experience breakthrough bleeding. So there are little few rules about how you're going to use extended regimen. So you generally don't want to use extended regimen on triphasic method, so you're going to use a monophasic pill.
Yeah,
generally, the lower the estrogen dose, the better. So 30 micrograms or 20 micrograms of EE. And then you just have to counsel your patient well, and then say, if you have spotting that lasts for more than 3 days, then take a 5-day break or a 4-day break, and then have your fake period and then restart.
Yeah.
Now, another thing that people say is, oh, well, aren't you now taking too many hormones? But actually, a lot of side effects that women can actually have, for example, menstrual migraines, is because you go from active pills and then nothing. So that's a good example. So sometimes it's those patients who specifically get menstrual migraines. Those are ideal to have extended regimen. And also, what people don't realize is that a 30 microgram pill is considered a low dose pill. It's just historically, I think we've forgotten, the pill started at 150 micrograms of EE. So the pill of my mother's generation is different to the pill of today. So the amount of hormones that we are using now, even if it's extended regimen, is much less than what it was in the previous generation.
Quite right. And somebody made the remark here that says periods are an inflammatory condition, are very unnatural. They should be avoided at all costs. Sorry for the interruption. Carry on, Judy.
No, you see, that's my problem. Once you get me started, I just can't stop.
Well,
So,
Yeah.
okay, so now sorry, my cat has decided to join the conversation as well. So that's, I'm just trying to keep her out of the screen. Yeah, so the progestogen, I'm going to talk about the non-contraceptive benefits of the progestogen-only contraceptives. So there's the trade name that we are very much familiar with in South Africa, but Levocert is a generic that is available in other countries. And what do we know about Mirena is that, especially for heavy menstrual bleeding and anemia, there's a 90% reduction of the amount of blood lost at 12 months. So it's also been used, it decreases your risk for endometrial hyperplasia and cancer, and actually can be patients who already have hyperplasia or maybe have early stage cancer where the oncologist can get involved, but that in a patient that you couldn't be able to operate for multiple reasons. Then also it decreases the rates of endometrial polyps, especially in your tamoxifen users, and then alleviates pain associated with endometriosis and adenomyosis. Depo-medroxyprogesterone acetate, or Depo-Provera, has also been used, well, in the state sector very commonly for heavy menstrual bleeding and endometriosis. And even the etonogestrel releasing contraceptive implant has been found to decrease pain and dysmenorrhea associated with endometriosis. So even those methods can be helpful for painful periods. So if you choose a combined hormonal contraceptive, you'll often have to consider the type, the dose, then also the regimen. And I've already mentioned the extended regimens. And then also there's different phasics, monophasic, biphasic, triphasic, quadriphasics. Then you also have to consider the oral, transdermal, and then the vaginal. And I think this is also the challenge with healthcare providers, is generally people use or advise things that they themselves are familiar with. And so this is also goes to the education of the healthcare provider, and knowing that's, I often like secretly roll my eyes when somebody says, oh, I use the pill, the pill's not for me. I'm like, well, there is so many options. It's not that simple. So let's look at the type of hormones that are used in the combined hormonal methods. So ethinyl estradiol, estradiol valerate, 17-beta estradiol, and for those of you not aware, there's a new kid on the block called estetrol, or E4. And I think that pill is hopefully going to be launched sometime this year. But I'm not going to talk too much about it.
Judy Smith on that, so you don't have to worry.
Yeah. So, but if you look at if you look at the metabolism of estrogen, I've also estradiol is metabolized to E1 and E sulfate, but EE is slowly metabolized and it's got a long half-life. So this is where sometimes you actually want to use ethinyl estradiol. Of course, every time that it goes through the liver, it has an effect on the liver. So of course there are negative effects on the liver in the extent that your clotting factors, etc., etc. However, we know that if you use a pill, which contains EE, it increases your sex hormone binding globulin. If you can see here in this table of comparison, it's 614 times more potent than E2 in your sex hormone binding globulin. And you might ask yourself, well, why should I know about that? Well, for example, your PCOS patient, where the problem is that they get the hirsutism because of the increased free androgen index. It's very rare that their total testosterone is raised. Sometimes you want the EE effect to increase your sex hormone binding globulin so it can bind the free androgens, and in so doing actually help with hirsutism. So a lot of people think, oh, the pill, it's the progestogen that's the most important for acne or hirsutism, but it's actually not. It's also the type of estrogen. Then your progestogen, you get different derivatives. I'm not going to go too much into that. And so, as I've mentioned before, there are many different types of pills, different doses, different regimens, different phases. So, and I think, and this is where people get a little bit flustered, because they're like, this is so many choices, where do I even start? And so people generally stick to what they know. But it's important, I think, if you have that you have some knowledge of the different hormones, so that you'll be able to use your hormones for the non-contraceptive benefits that a woman might actually want. So we know the steroid hormones have an effect on your progesterone, your estrogen, your androgen receptor, either by blocking it or stimulating it. They can also block your mineralocorticoid or your glucocorticoid receptor or stimulate it. And so if all these synthetic steroids or hormones that we use can have beneficial effects, but also side effects. And what I liked about Donnie's talk the other day was he said, nothing that has an effect doesn't have a side effect. And if it doesn't got a side effect, then is it really working? So if you just simply look at your progestrogens that are derived from testosterone, you can see they're different properties. Some are more androgenic than others, some are more anti-estrogenic. So I'm going to just talk about the newer progestogens, because Dynagest is on its own is called Vazan. There is now a generic on the market. And for those of you who don't know, Dynagest only pill is only marketed for endometriosis treatment, but with the side effect of not falling pregnant. It's not marketed as a contraceptive, but it is in a contraceptive called Clara. So Dynagest is has got anti-androgenic activity, about a third of cyproterine acetate. And what is nice is that it hasn't got mineralocorticoid or corticoid effect. Then there's the drospirenone, which is in your Yaz and Yasmin. This is now progesterone, which is anti-androgenic, and anti-mineralocorticoid, hence helping with those PMS symptoms. And then Nomagest.
Sorry, Judy, just go back one slide. The Vazan thing, Dynagest, it comes in Vazan.
Yes.
What did you say about Dynagest alone? Is that a contraceptive or not? Vazan. If your woman's on Vazan.
So this is my, sorry, I was talking a bit fast, but what I was trying to say is, this is the funny thing for me. Dynagest is essentially a progesterone only pill, but it is not marketed as a contraceptive.
Yeah.
But if you read the package insert, it says you might have difficulty. I don't know, I haven't read it recently. You might have difficulty falling pregnant. So the side effect of Dynagest is you won't necessarily fall pregnant. So that's my little joke that I say, is that this is just shows you how you portray these hormones, because there are many contraceptive hormones that we use for its non-contraceptive benefits. And this is a pill where it actually has got, it's a very strong lawnmower. So in it, that's why it's such a good treatment for endometriosis, but it is not, it hasn't been marketed as a contraceptive. Does that make sense?
Are you likely to fall pregnant if you're using Vazan?
No, not necessarily, no.
So
it's like
Clara. If you're using Vazan and you don't want a baby, must you also use condoms? That was what I'm saying.
Yeah, so it's not a very reliable, well, I can't tell you, this is the thing, is because it's not been it's not been manufactured as a contraceptive. I can't actually tell you what the failure rate of Dynagest is, but it's essentially, if you think about it, it is actually, it's not, you actually have to counsel your patient that if you're on Dynagest, and you're wanting to fall pregnant, you might have difficulty, if that's what I'm trying to say. There is also the combined contraceptive pill called Clara, which is actually a combination of your estradiol, valerate, and Dynagest, but that is actually marketed as a contraceptive.
Yeah, sure. Now, if you're on,
trying to say,
that's Vazan. If you're on Dufaston, apparently you can fall pregnant quite easily on Dufaston. Is that correct?
Yeah, I think so. Dufaston is, I think it's I have to go back. It's the dihydrogesterone. So you can see it's a progesterone derivative, and it's not as potent. And I think that's why people like Dufaston, because I think it's a, my chemistry is up to maggots, but it's a flip of progesterone. I don't know how you put, what's the correct word. So it's yeah, it's not a very potent, it's not able to suppress ovulation like other methods, like other progestogens.
Yeah.
So that's why it's not a contraceptive. So even if,
So sorry to interrupt you, but basically, I mean, this is an important discussion though, because you'll do laparoscopy and see some endometriosis. You want to start a patient on something to treat it, but they want to get pregnant as well, or they might not want to get pregnant. And that whole negotiation or discussion around the role of Vazan in contraceptions is quite a big thing. So, but I generally do tend to put the patients on Vazan, and I mean, I think I did speak to one of the fertility guys, and they said it is actually quite an effective contraceptive.
Oh, really?
But you do need to write in your notes that you did warn the patient that it's not a contraceptive. But I do find this a difficult one actually. There is a,
so that's the.
There's someone saying, from Zelda, Bayer has not conducted clinical studies to determine the Pearl index for Vazan as a result. Vazan is not indicated for use as a contraceptive.
Yeah.
So, you know,
So
there we
that's a
go.
much better answer than I have. It's that we don't we don't have the literature to say, because I think
Anyway, we've
it's
interrupted you enough. Sorry, Judy, we got sidetracked a bit.
Yeah. So it's likewise if you think about hormone replacement therapy. The hormones that are used in hormone replacement therapy are not necessarily potent enough to be a contraceptive. And we're going to get, hopefully, if we have enough time, get actually to that bit but let me actually whiz through. I'm going to just go through it because I actually wanted to get to that bit. So I wondered, I've got a bit about adolescence, but I wanted to focus about the perimenopausal woman, but just quickly rushing through adolescence, the thing with, if you look at the Pearl Index and the typical use failure rates, so the Pearl Index is not an absolute. It depends on the population, how long the patient has been using it. But I like to use the typical use failure rates are generally the failure rates in the first year of use. But we must remember that in different populations, the failure rate is differs. So especially in the teenager, your typical use failure rate is actually higher, 15 to 26% versus 9%, because it relies on the user to remember to take something, and the teenager is not necessarily the reliable user. What also about what might prevent young women from taking contraception is their weight gain. That's very topical. And there's no evidence that combined hormonal contraception increases weight. Of course, it's in the package insert because they have to mention everything that's an association, but it's not necessarily a causal association. So the one that's definitely got a causal association is depomedroxyprogesterone acetate. Then what about mood changes and depression? Well, hormonal contraception may be associated with mood changes, but there's no evidence that it causes clinical depression. So it's often the patients who already had a propensity to clinical depression who become depressed. So the method on itself shouldn't go put you into clinical depression, but that's often a concern, especially with lay media. I'm going to just whiz through about, because I'm going to talk about bone health a little bit later. Also, adolescents are more likely to have anovulatory cycles, heavy bleeding, and dysmenorrhea. And we know any contraceptive, hormonal contraceptive, can improve this. And then the big one, acne. So any COC can improve acne, even that a contraceptive that has an androgenic progestogen in it, because it's not just about the progestogen. So we know that there's a suppression of the LH-driven androgen production by ovaries if you give any COC. And I've already mentioned the effect of EE on your sex hormone binding globulin and your subsequent decreased free androgen index. So if the initial COC fails to improve acne, then you can switch to one that contains a less androgenic progestogen or one with a higher estrogen content. So what about the progestogen-only methods? So we know that androgenic progestogen, if you are taking away the estrogen, the EE, or you're not having the EE and you're giving an androgenic progestogen, of course, your acne might worsen. For example, your levonorgestrel containing methods. So your pill, Microvel, your acne might worsen. And then also levonorgestrel intrauterine system, there might be a transient increase in acne in the beginning, but generally the longer with the Mirena, the levels actually fall, so your acne can actually then improve. So that also goes down to counseling, because I have heard of a few women who don't like go from the pill to the Mirena, and then they say, oops, I don't like, my skin has flared up, please take out my Mirena. So it's important to consider these things when you discuss the contraceptive. Okay, I'm going to just whiz onto the perimenopause. The reason why I wanted to mention this is that the proportion of women having unplanned pregnancies in women older than 40 are the same as in young women. So in other words, the fertility rate declines, but those women who are actually falling pregnant older than 40, the proportion of unplanned pregnancies are the same as younger women. So this tells me that both the healthcare provider or the women themselves don't realize that they still need to be on contraception. And the problem with pregnancies in this age group is that they're at much higher risk for maternal complications. So let's look at what other conditions women might have in this age group that might warrant a contraceptive for its non-contraceptive benefits, and that's irregular and heavy menstrual bleeding. I remember reading, I don't know if it's the NICE guidelines on heavy menstrual bleeding, that in the UK, since they now advocate Mirena as the first line medical therapy, they do 60% fewer hysterectomies than before. We know that so Mirena definitely is a first-line medical management for irregular and heavy menstrual bleeding, for which you've excluded an underlying structural cause. That's just the disclaimer. We know any combined hormonal contraceptive can actually help regulate the periods, but once again, you need to be mindful about the skedonk of the car. If the car is that means your risky patient. So if you have a patient who is morbidly obese, smokes 30 cigarettes a day, who has hypertension, then you probably shouldn't, well, you must stick to the rules. Don't give them a combined hormonal contraceptive, rather than use a progestogen-only method that doesn't add to their risk of clots. I mentioned already before that E2V Dynogest, otherwise known as Clara, is an FDA approved for heavy menstrual bleeding. So it's not only approved for a contraceptive, but for heavy. And so that's why it's a nice pill for this age group. Often people use Depo-Provera because the longer by a year of use, about 70% of women will be amenorrheic. The problem I see this often used in the state sector, but the problem with this is that actually after 45, the WHO makes Depo-Provera MEC 2, which means there might be some risk. And the risk is your bone mineral density declines. Normally, when you stop it, it recovers. But you don't want to give Depo-Provera in a woman who's going to go through menopause, because I think you lose something like 50 to 20% of your bone. You don't want to now add, you don't want to make them lose bone mass and not have the ability to recover before they actually go through menopause. And then the other scenario is hot flushes and vaginal dryness. So any estrogen containing can help those symptoms. So the problem is everyone thinks, oh, let's give them HRT, but forgets that you actually still need contraception. So every now and again, you hear stories of eclampsia. And then not to forget about the continuous and extended regimens that you can use. This can help improve those cycle-related symptoms like tiredness, bloating, and menstrual migraine, as I've mentioned before. The only downside is the unscheduled bleeding, but then this can be improved with short hormone. So what does the Faculty of Sexual and Reproductive Health say about contraception in this age group? So I've looked at it now recently, so it was updated now in May 2025, and it's pretty much the same as what it was. So if you've read it in the last 10 years and you remember it, it's pretty much the same. But just to bear in mind, they do advise that if you put in a Mirena, a 52 milligram levonorgestrel system after the age of 45, you can actually use it till 55. And why 55? Because 55 is the age where there actually is the 95th centile of menopause. and generally the fertility rates are so low that it's considered that's when you can actually stop contraception. So even though Mirena is registered as a contraceptive for, well, it's 5 years in this country, but FDA approved for 8 years. In this age group, 45 and older, you can use it up until 55, in other words, 10 years. However, if you're using it for endometrial protection with estrogen, then it goes back down to 5 years. I feel that the Mirena is not won't provide you adequate endometrial protection for more than 5 years. So then the scenario changes. Also, the faculty states that if you're over 40, one actually should, and this is without the consideration of the meningioma and the depot that SAPRA has now raised, that you should actually regularly assess the benefits and risks of use in this group. And the reason why is because of the bone mineral density issue. So you can understand when I showed you that first slide of that 40-year-old gravida 10 para 9 who's still got the injection marked as a contraceptive choice. This is the woman you have to actually sit down and say, you know what, it might have worked for you for the last, well, you could debate whether it actually worked for her, but but now that you're 40, even though you can use it, let's consider, this should be motivation enough to say, let's consider your alternative options. So when do you stop contraception? Well, you stop it when you know the patient's gone through menopause. But the problem is, how do you know someone's gone through menopause if they already are using a hormonal method and are amenorrheic? So the Faculty of Sexual and Reproductive Health says, well, I know even though we define menopause as a retrospective diagnosis with amenorrhea of a year, the Faculty of Sexual and Reproductive Health says, well, actually, if you're using a non-hormonal method, for example, like a copper IUD, and you're younger than 50, they actually advise only stopping that method if you've got 2 years of amenorrhea, and it's only if you're older than 50. Then you can remove your method if it's 1 year amenorrhea. What about your combined hormonal contraceptive methods? Well, you can use a combined hormonal contraceptive method until 50, as long as there's no contraindications to its use. So, but then generally advised to stop CHCs after 50 and switch to a non-hormonal method or a progesterone-only pill method. Now, some of you might say, but isn't HRT also a combined hormonal method? And the answer is, it is combined hormones if you are giving it as such, but the potency of the estrogen generally, well, depends on which ones you're using it. But for example, your ethinyl estradiol containing estrogen is much more potent than the estrogen used in HRT. So you probably should change because of the risk of VTEs that's correlated. And then also considering your route of administration as well. Depo-Provera, it's also advised that to stop it after 50 and switch to a non-hormonal method or a lesser a progesterone-only method like POP, implant, or levonorgestrel intrauterine system. Then the other implant, POP, and levonorgestrel can be continued longer than 50, so generally 55. And now another thing that I often see people do is they do blood tests. Well, the faculty to try and diagnose menopause. And I think this is also we can get ourselves into trouble because there's fluctuation levels in your FSH, and your FSH increases before you hit menopause. Now, you might ask, well, why, if you're going to check why FSH? Well, if you're on a progesterone-only method, that doesn't suppress FSH. It will suppress your LH. So that's why if you're really going to use the levels to try and figure out whether you should stop the method, you will only do FSH, not LH. But if you're going to use it, you mustn't use it younger than 50. The faculty recommends after 50, and then you have to do at least 2 levels, at least 6 weeks apart. And if both of those levels are more than 30, then you still have to tell the patient you need to use contraceptive for another year. So I don't know about you, but that's costly and very labor intensive. And so the Faculty of Sexual and Reproductive Health is, if you cannot determine if they've gone through menopause because they're not using a non-hormonal method, basically just use the method until they're 55. So I hope that is clear as crystal clear and not clear as mud. But basically the bottom line is use contraceptive until 55. If you want to use hormone FSH levels only after 50, and you still have to have 2 levels and still use for another year if they are high, more than 30 on 2 occasions, 6 weeks apart.
Thank you.
Just to finish, I know, I think I'll just finish that. I think let's just finish that there. But there is also some advice about hormone replacement therapy being used alongside contraception, but hopefully I've sort of touched on that already in the general discussion. So I think I'll just leave that there because I see I'm over 6.
Yeah,
Steve?
yeah, thanks. It's been wonderful. You know, we always learn so much, and there's just so much to know. I just wish you could carry on longer, and maybe we can have to get you back to finish. But Erwin has actually waiting on this issue of the meningiomas, and he's saying, Erwin Gertner, thanks Erwin for the comment. It may be of interest to know that Prof. Delenn Lubbo, who's the ENT professor at UCT, has published on cases of meningiomas. She has operated on in Cape Town and has also been interviewed on carte blanche in terms of the situation of depo and meningiomas. I would be interested to go and chase that up. Maybe we should go and see if we can
Google
find
that.
There are other questions here about bleeding on both the Implanon and the Mirena, but I think we don't really have time for that now, Peter. Maybe we should all do that another time. What do you want to?
I definitely will,
Yeah,
because
yeah.
there's lots of questions, but we're going to have to revisit these, Judith.
Yeah.
Just
So
to,
just to let you
Yeah.
know, there is the Faculty of Sexual and Reproductive Health have guidelines for almost everything. And there's a guideline on breakthrough bleeding on progestogen-only methods. So that's in a talk in its own, and I actually have that talk as well. But there are resources. If you have these questions, you can just go and look for them.
Faculty of Health and
No.
Sexual Medicine.
But thanks so much, and we'll definitely need to get you back because I think you've opened up lots of questions. There's a lot to say here, and I think the point really is that we can do this better. You know, a lot of us will write up a little bit of Yaz or Yasmin and send the patient on their way without really talking to them about what the other options are. And there are some newer things available that we need to know about. And, you know, we can take patients to a point of where they are doing the contraception better with better options. And we look forward to having you back again, Judy. I know you very wisely going along a Urogyney route, but I mean, your contraceptive knowledge is very useful to us, and we love tapping into it on these webinars. And so we'll have you back definitely. But good luck as you delve into the pelvic floor issues as well.
Thanks again.
And,
Thank you so much.
And we really appreciate you, you know, coming almost as a last minute, you know, invitation. But thanks for being available. We really appreciate it, and we really enjoyed that. Thanks so much.
So next,
Thank you.
while we thank you, we'd just like to next week is Imran Mia, and he's speaking about bowel complications and obstetrics and gynecological surgery. We look forward to that. From all of us over here at Cape Town, a great good evening to you. Thanks to our sponsor, Zelda of Bayer. It's been wonderful having you over here. And it'll be quite remiss of me not to mention thanks to Steve for the use of his minibar. Thanks, Steve.
As always.
See you all same time, same place next week.
Thank you very much.
Good night and good luck.